And with that, I would like to introduce our very first speaker for our opening session, Dr. Yvonne Ou, who is going to present on what is glaucoma and what are some of the clinical aspects of glaucoma. Yvonne?
Okay. Thank you. Thank you so much for inviting me to give this talk, and thank you to the organizers, Colleen, Becky, Abe, and Diane. And I was tasked with this question, what is glaucoma? These are my disclosures that are not relevant to this talk. And so when, what is glaucoma? It's like an existential crisis, like, what is glaucoma? I'm gonna try to study this disease and I need to understand what it is. And believe it or not, it kind of is a big question still, in a way. And it reminds me of times that we spent in Dave Epstein's office when I was a clinical fellow at Duke. We would gather together on Monday nights to discuss what is glaucoma, why is it happening and manifesting in this way, and we would take patients' scenarios and cases that we had seen during the week and discuss them and use them as a launching point. And it was a group of medical students, residents, fellows, and if those of you in the audience some of you may recognize Lucinda Camrus there. She was a biomedical engineering student at Duke at the time, and so it was a really fruitful and engaging way to spend our Monday evenings discussing glaucoma. And Dave Epstein was the editor of several editions of Chandler and Grant's Glaucoma. This is the 4th edition, and Chandler and Grant were his mentors. And when I still, want to hear David's voice, I go to this edition. And he made such an influential impact on my clinical learning, but also my scientific thinking about glaucoma. And he says in the foreword here that he wanted to try to write a book on glaucoma that would give practical information to the clinician dealing with an individual patient, and yet at the same time stimulate all of us to ask why. What is the mechanism for the clinical observation, and how might we better be able to treat the condition in the future? And so I wanted to give this talk in a way to help you think about what we think about glaucoma as a clinician, and to use that as a launching point to think about how we can improve things for our patients. So the goals are to build a clinician's mental model of glaucoma, and we're gonna spend, kind of like a day in the clinic in OR, understand detection, staging, and treatment, and also spend a little bit time at the end talking about what are the unmet clinical needs and how can you help us meet them. So glaucoma is a group of diseases with characteristic optic nerve cupping being the final common pathway. And I say quote unquote characteristic, and you'll see why in a moment, but here is a color photograph of an optic nerve. There is the center part that is called the cup, and the disc is, and the rim is the healthy neuroretinal rim tissue that you see there. And then in histological cross-section, you can see that there is this small depression. And then in glaucomatous optic neuropathy, this is a very advanced stage of glaucoma here that's being depicted. You see loss of that neuroretinal rim tissue, backward bowing of the lamina curvosa. Eventually the nerve does become more pale because of that loss of that healthy pink tissue. And on histological cross-section, you can see this cupping. And this particular nerve is what we might call a bean pot cup, colloquially. And the bean pot, I think, comes from, I grew up in Boston, did some of my training in Boston, and I think the bean pot, it actually does kind of look like that bean pot, that silver trophy there. This is a hockey tournament that happens annually for the 4 schools in Boston. But defining glaucomatous optic neuropathy is still an active area of discussion. We have groups that are trying to understand and define the optic neuropathy so that it can be better used in AI research and clinical applications, and for understanding how we can define it using objective criteria from structural and functional testing. So as I said, I think there are still nuances because of that definition of having that characteristic appearance of that optic nerve head, which we're going to dig into a little bit during this talk. But let's take a step back and also think about what's going on in the front of the eye. Of course, aqueous humor is being produced by the ciliary processes depicted here. There are about 80 of these in the human eye. And then the fluid is produced and then goes around the lens into the anterior chamber and then out through the drainage system. Here it's not depicted, but there's the trabecular meshwork and then Schlemm's canal. And then on this side, they're showing here that there are aqueous veins draining into episcleral veins, and that will become also important on the next slide, where we do see a pictorial drawing of the trabecular meshwork. This is from the histology of the human eye. And we have multiple locations of resistance to outflow. There are many experts of those locations in the audience, so I'm only going to spend very brief time talking about it here. But we have the juxtacunicular trabecular meshwork, as well as the collector channels, and the pupil actually acts as a location of resistance to outflow. And as I mentioned on the previous slide, there's also episcleral venous pressure, which you can kind of think of as the afterload. There is essentially when you're using medications, for example, a floor to which you can lower the eye pressure, because whatever that episcleral venous pressure is, you're not going to be able to lower pressure below that. And then here is a pictorial illustration of what's going on in glaucoma, where the ganglion cell injury starts at the optic nerve head. And so I just wanted to show this again here because I thought it very nicely illustrated that backward bowing of the lamina crebosa. In the top image there, it's sort of depicted, the lamina crebosa is depicted in those gray lines here going horizontally, and then in the bottom here, you can see that those have now bowed backwards, and there's excavation of the cup and progressive loss. As those axons traverse the lamina crebosa and traverses those pores of the lamina crebosa, there can be axonal compression, and that is thought to be the initiating injury in glaucoma. So the American Academy of Ophthalmology puts out a preferred practice pattern guideline for glaucoma, for different forms of glaucoma. There's one on primary open-angle glaucoma, and this is where this definition comes from. And it states that primary open-angle glaucoma, which is the glaucoma that we are going to focus on today, is a chronic progressive optic neuropathy in adults in which there is a characteristic acquired atrophy of the optic nerve and loss of retinal ganglion cells in their axons. And there also is a requirement that the anterior chamber angle be opened by gonioscopy. But what isn't in this glaucoma definition? You'll notice that IOP, intraocular pressure, not part of the definition. Visual field deficit, not part of this initial part of this definition of glaucoma. And the drainage angle is mentioned. It's said, it has to be open, but is not explicitly identified as the diseased tissue. So what is in the glaucoma definition? The preferred practice pattern definition goes on to say that there needs to be evidence of optic nerve damage, and that evidence either needs to come from an optic disc or retinal nerve fiber layer abnormality, or a reliable and reproducible visual field abnormality, and it can be also both. It needs to be adult onset. Again, the angle needs to be open, and there needs to be an absence of other secondary causes. Indeed, you can consider primary open-angle glaucoma as a diagnosis of exclusion. This is not a comprehensive list of all the different types of glaucoma, but it shows you, as I said, glaucoma is a group of diseases. And so I have normal tension glaucoma here, asterisk. We'll talk about whether or not that really truly represents a separate disease. But you can see there's lots of other forms of open-angle glaucoma, some of which are listed here. There's also angle closure glaucoma, including primary angle closure glaucoma, but then also secondary forms, some of which are listed here. And then there are glaucomas which could be mixed mechanism. There can be, in uveitic glaucoma, a component where there is an open angle, but over time there can be scarring that forms in the drainage angle, and that can lead to more of a closed form of glaucoma. So is normal tension glaucoma really a separate disease? And here I go back again to the preferred practice pattern guideline, and I think there's still debate in the field about whether this is a separate entity. There's sort of phenotyping or endotyping that can to help us distinguish between the two diseases, but I would say that in general, we think of it as a spectrum, that primary open-angle glaucoma is a spectrum of disease in adults in which the optic nerve is differentially susceptible in different patients. And up to 40% of patients may not have elevated IOP measured in clinic. Whether that means they might be having IOP spikes outside of clinic hours that we're just not capturing when we measure IOP is up for debate. And I think certainly the field has been and still continues to move towards a paradigm in which we can measure IOP more often than, say, once every 4 months or 6 months. But it also does emphasize, again, that IOP alone cannot be used to screen for primary open-angle glaucoma. So what is the patient's timeline and perspective when they're diagnosed with this disease? Well, they can be asymptomatic for years, and that's why glaucoma is often called the silent thief of sight. And we can talk about why that might be. Some of that is due to the fact that glaucoma typically starts with peripheral vision loss, and then it can be slowly progressive, and of course, it can be asymmetric. So you can have a much healthier eye with a much more diseased eye, and then one eye might compensate for the other, and you may not notice that glaucoma is ongoing. It requires lifelong monitoring and treatment, and this is how I couch success to my patients. We are trying to slow progression below a critical rate while undergoing treatment with minimal side effects or impact on quality of life. So I'm going to show you a quick video of a patient of mine who I interviewed on Monday about their diagnosis. She's done a lot of public speaking about her glaucoma diagnosis, and so I thought she'd be perfect for this. And she was diagnosed 14 years ago, and actually at a quite advanced stage in one of her eyes. And so she's going to talk a little bit about what that's been like.
Definitely was surprised. I had an eye pressure of 56 in my left eye. And I remember the nurse kind of saying under his breath kind of a profanity. Like, I think he was very shocked, and I didn't really know what having a high eye pressure meant. So yes, I was definitely very, very surprised. Of course, I was one of those people that thought I can see fine, so my eyes must be fine. But 14 years later, you know, I'm still fine, so yeah.
And I'm glad she's still fine. You know, that's been part of our job together to make sure that she continues to have slow progression. And this figure illustrates various different modalities by which we measure structurally and functionally. And we're going to go over each of these in a bit. At the top, you see color photographs of the optic nerve. On the second row are OCT, Tisnet maps, and I'll explain what that is. In the third row are visual field, perimetry results, and on the fourth row is what the patient may perceive. And so you can see that as glaucoma progresses, it can start with mild glaucoma where there is no visual field defect, all the way to complete blindness. And even at this stage, in which we say that there's a central island of vision still left in the center, the patient is still measuring 20/20 in the clinic when we do the eye chart. And so, again, just to emphasize that it is a slowly progressive disease, and we want to keep people hopefully more on the left side of this journey. So I'm going to take you through a day in the glaucoma clinic. That involves taking a patient's history. We talk about their risk factors, measuring their visual acuity and IOP, their corneal thickness, which is a process called pachymetry. We do a slit lamp examination in which we measure their eye pressure as well as look at their drainage angle using gonioscopy, and then some of these other diagnostic tests that we do that I've listed down below. So the risk factors of glaucoma include this long list. Some of them you'll note are related to characteristics, systemic diseases, blood pressure. Some of them are related to ocular factors, such as having a history of myopia or having a thin central cornea. But of course, the top one here is elevated IOP. It's a major risk factor for the development of primary open-angle glaucoma, and of course is our only modifiable risk factor truly at this time. So we're going to talk a little bit about how we measure IOP in the clinic. And we use the Goldman equation. Actually, I'm just joking. We don't do this. We don't do this. We don't do the math in our head every time we measure IOP. But it is based on the Goldman equation, where we're looking at aqueous formation divided by outflow facility plus the episcleral venous pressure, which is the afterload I mentioned before. The classic way of measuring IOP, and which I still do every single patient today, although it has its caveats, is Goldman applanation. And it's been around for a long time, as you can see, over 70 years. And it is based on the fact that when you have the area of a flattened cornea to balance the capillary attraction of the tear film for the tonometer against the stiffness of the cornea, and assume a corneal thickness is 520 microns, which not everybody is, and taking into consideration the diameter of the tonometer tip, you get a measurement of IOP. And so what's depicted here in the lower left are the Myers that you see through the prism tip. And it is still a subjective measure, because you can see in the bottom right here, depending, sometimes if you have too little dye in the eye or too much dye in the eye, it will affect the measurement. But it is a quick and easy measurement. This is my glaucoma fellow that I videoed yesterday, letting me check her eye pressure so that you can see what this process is like. We did this in one take, so there's a little aspects of it that are missing here that next time we're gonna capture. But in the bottom center part, there's a reticule which you're turning to measure the eye pressure. And then there are also other methods of tonometry, including pneumotonometry, which I also like. We don't use as much anymore on a regular basis, primarily because of the issues with replacing the tip every time you use it, which can be very expensive. But it is a device that has a smaller area. I think you can kind of appreciate that I'm holding the tip there, or holding the device, and then the tip at the end is quite small. And it's based on measurement on a column of air, although it is not an air puff tonometry. I didn't list actually those types of tonometers, but those are typically used oftentimes in optometry offices. And then on the right, I'm holding an eye care, which is a rebound tonometer. Now this one is gonna look familiar to you. This is Tonolab, but in the human form, called eye care. And doesn't require anesthesia. It's a rebound tonometer bouncing off the cornea. And then not shown here is another contact tonometer called Tonopen. We also want to measure corneal thickness, and this is important because it is a risk factor, as we talked about earlier, for glaucoma. And then, you know, some of the measurements of eye pressure are impacted by the corneal thickness. So, for example, Goldman applanation tonometry, I told you, assumes the thickness of the cornea is 520 microns. Well, not everybody is there. Some people have thick corneas, some people have thin corneas, and if you have the thin cornea, for example, when we measure your eye pressure, it may be artificially lower than what the true pressure is. Next, I'm just gonna show you a video of gonioscopy from Lee Allward's excellent website called gonioscopy.org, and you cannot see the drainage angle because of total internal reflection. And this is actually his daughter that he is doing the video with, who also is a glaucoma specialist. So here you have to, this is a 4-mirror gonioscopic lens. That band of tissue that just went by is the pigmented trabecular meshwork. You can see the eye obviously needs to be anesthetized when you do this. This next part of the video is showing you that you're kind of, you know, balancing this lens on the cornea. You don't want to compress the cornea or push too hard, because that may artificially open the angle as you examine it. What's not shown here is there's light in this room, but typically gonioscopy is performed in the dark because you don't want the pupil to constrict to light and then artificially open the drainage angle as well. So here you can see that the air fluid interface is kind of constantly shifting because he doesn't want to press too hard as he's doing it. And so this is also still, I would say, our reference standard for determining the status of the drainage angle. But as you can imagine, it is also a somewhat subjective process. It depends on lighting conditions, the operator who's doing the observations. And there are other ways now of measuring the anterior segment, anterior chamber width using what's called anterior segment OCT. This is non-contact, it's pretty fast. And this is a patient I saw yesterday who I grabbed their two images to show you the difference. On the right-hand side, which is the right eye, this patient has had cataract surgery, and you can appreciate the cornea here is at the top here. You're just looking at everything in cross-section, and then here we're looking at the drainage angle, just in this single cross-section though. So it's not like the 4-mirror gonioscopy exam where you're looking 360 degrees. There are now devices that do 360 degrees swept source anterior segment OCT, but they're, to my knowledge, not available here in the US yet. So this is open, and then his left eye is more narrow. And you can appreciate here this peripheral iris roll here that's almost touching the trabecular meshwork and almost causing full iridotrabecular contact. The next part of the exam will include examining the optic nerve, and this is from Chandler and Grant's Glaucoma, that book that I showed you at the beginning of the talk. And here they say that in the diagnosis of glaucoma, the appearance of the optic disc often provides us with valuable clues. And it tells us also whether our treatment is adequate, and I'll explain to you what I mean by there. And then also we often obtain essential guidance. And so when I give a talk to the residents about optic disc evaluation, I tell them that's our whole job, is to be good detectives of the optic disc. And so this is a clinical view of the optic nerve, although it's not truly the clinical view. And when we are examining patients at the slit lamp, we actually get a 3-dimensional stereoscopic view of the optic nerve, so we can really appreciate the depth of the optic cup. These, of course, are 2D images that you can't really appreciate those, but that's that drawing in the center there is showing you the excavation that can happen and that cupping that I've been talking about. And so we need to understand first, what does the normal optic nerve look like? And you may also, when you're reading papers, read about cup to disc ratio. And what they're talking about is that here in the yellow is the cup. They've artificially, the pink healthy tissue is here in orange. And then the cup to disc ratio is really, what does this, for example, the vertical cup to disc ratio is, what is the ratio of this height compared to the total height of the disc? The disc is typically slightly vertically longer than it is horizontally in diameter. And one of the first things we talk about is defining the size of the disc, because that can impact your thinking about that particular optic nerve. On the left here is a normal sized disc with a vertical cup to disc ratio of 0.3. You might see that in notations or in textbooks. That's sort of classically thought of as a normal cup to disc ratio. And then in the middle is a large normal disc with a large cup to disc ratio of 0.7. So the question is that glaucoma? Here we're saying that it is not, because it actually has a healthy neuroretinal rim. It obeys what is called the isn't rule, where the inferior nerve is retinal nerve fiber layer is thicker than the superior, retinal nerve fiber layer thicker than the nasal and temporal, and so on and so forth. But this same cup to disc ratio on the right in a small nerve can be pathologic. And also in this picture on the right, there is focal neuroretinal rim thinning inferiorly. And so this is a glaucomatous disc in a small optic nerve. And this can be very tricky to discern, and I would say actually small optic nerves, sometimes I see patients referred in telling me that they were diagnosed, all of a sudden, but the reality is it was ongoing. It was just probably missed, because it is sometimes difficult to pick up, especially in small optic nerves. And another place where it's difficult to diagnose glaucoma, and I just put this up as an example, are those discs that are in high myopia. So these are discs that have all these different tilts. For example, this one's sort of tilted supratemporally. There's also this area of beta zone or parapapillary atrophy that you oftentimes see in myopes. This one's tilted more temporally, and this nerve is very hard to distinguish. You might think that this is the disc here that I'm outlining here, but the reality is this disc is super tilted. This is the small optic nerve that is very tilted, and this is actually beta zone atrophy. So how do we determine if we're adequately treating patients? One thing that we always look for that cannot be captured by some of the other tests, it's captured by a photograph, That's why, and I'm going to show you some photographs, but we don't always get color photographs every time we examine patients. We always get an OCT. I'm going to talk about that in a bit, but OCT cannot detect disc hemorrhage. What I'm doing every time I look at the patient and examine their nerves is I'm looking for disc hemorrhages. And optic disc hemorrhages can involve the disc rim, it can involve the retinal nerve fiber layer around the optic nerve, and it can involve the lamina cribrosa. And in the ocular hypertension treatment study, the incidence of primary opening glaucoma in eyes with disc hemorrhage was 13.6% versus 5.2% in eyes without without disc hemorrhage. And the presence of disc hemorrhage and the percentage of visits that a patient had with disc hemorrhage are associated with progression by visual field defect or optic nerve damage. So the next slide is showing a series of images from one of my patients from 2010 to 2022. And you can appreciate that there are some recurrent disc hemorrhages that slowly start to appear. For example, here in 2017 at 6 o'clock, and even here earlier at 2016, it's not so obvious, but there is one as well. And then in 2018, another one shows up just off the disc in a different location. And again, just so you know, these disc hemorrhages come and go. So it's not like these disc hemorrhages stay from 2016 to 2017. They resolve, they reabsorb. Why they occur is also a very interesting question and may be related, lots of different hypotheses, but might be related to deformation at the optic nerve head leading to the breakage of fragile vessels, or might be vascular in nature from the very beginning, not necessarily completely related to stress or strain experience at the optic nerve. There may be vascular dysregulation leading to these little disc hemorrhages. What I think also is important, so disc hemorrhages are like a red flag alert to me. They're saying, hey, this patient's glaucoma is not well controlled. You better do something about it. And you can see that these disc hemorrhages also predict, you know, she's had recurrent disc hemorrhages here inferiorly. And in the last photo here in 2022, if you trace this vessel here along, this inferior vessel, you can see that the curvature of that vessel has changed from back in, say, like 2013, where the curvature of that vessel is less acute, and now all of a sudden it's kind of dipping down. And that's because there's loss of neuroretinal rim tissue and now changing of the course of that vessel. So when we don't have time to go through the entire systematic optic nerve evaluation here in today's talk, but these are the elements that I teach the residents about examining all the different aspects of the optic nerve. And I put there at the bottom retinal nerve fiber layer because you can measure or you can detect retinal nerve fiber layer defects at the slit lamp using a red-free light. But of course now we have a much easier, faster and accurate way of measuring retinal nerve fiber layer, and that is optical coherence tomography, or OCT. Those of you who have been paying attention, this is the exact same video that I showed you earlier of my fellow, and that is because this particular device measures both the anterior segment, OCT, and the posterior segment. And so this is a figure from Hiro and Adriana DiPolo and Brad Fortune in a recent review paper, and I encourage you to go read that paper. I also encourage you, because I'm going to spend very little time today talking about OCT, to go watch Dr. Schumann's talk from a previous fast track about OCT. But OCT is amazing. Spectral domain OCT gives you the three-dimensional anatomy of the retina with nearly cellular scale resolution. You can see here that in panel B that there is OCT will measure what we term the ganglion cell complex, which is the RNFL, the ganglion cell layer, and the interplexiform layer. But there are also more and more advancements in OCT, better segmentation algorithms. I would think that in the future we're going to be able to measure these layers independently, not necessarily just as a combined ganglion cell complex. And then in panel C, we have a cross-section of the optic nerve, and we can measure things parameters such as Brooks membrane opening and minimum rim width to measure, as well as thickness of the retinal nerve fiber layer 360 degrees around the optic nerve head. And so this image is a printout of a patient who I saw yesterday who you're going to be like, why have you been taking better care of his glaucoma? He looks like he's progressing. And that is because he has been progressing, and we have been advancing his treatment over time. And most recently, he actually had a trabeculectomy a few months ago. So this is in the top panel showing you that ganglion cell complex thickness map, and it's made real obvious to clinicians looking at these in clinic, because you can see that the red is highlighting those areas which are thinner than what would be expected compared to a normative database. In the second row is the nerve fiber layer analysis. There's numbers around the clock hour of that optic nerve head, so we're comparing and looking at those thickness maps. Now again, there's still noise, even though I told you this is an objective measure of the retinal nerve fiber layer thickness. There will still be noise. There are artifacts that is going beyond the scope of this talk, but regardless, you can see clearly that there's a trend here on that bottom left, measuring the retinal nerve fiber layer rate of change. One thing I don't love about this particular output is that it assumes that the rate of change is 0, and actually in aging, we know that there is some retinal nerve fiber layer thinning that happens over time, and this does not necessarily take into account. And this is, by the way, only one of 4 different manufacturers that produce the OCT, and unfortunately, one of the things that I find frustrating is that they don't, it's hard to make direct comparisons from manufacturer to manufacturer. The right-hand side here is the TISNet map that I talked about or briefly mentioned earlier. And this is just laying out a retinal nerve fiber layer profile. You can see that we are thickest superiorly and inferiorly, and thinnest temporally. And it also shows you, so it's laying it out, the retinal nerve fiber layer thickness from temporally, superiorly, nasal, inferior, and gives you an assessment both of the baseline retinal nerve fiber layer thickness in black, and then the subsequent traces. And then also in the upper right are measurements of other optic nerve head parameters. It will give you a measurement, for example, of the cup to disc ratio. On other printouts, it will tell you, for example, the disc area. So we're going to next move to a functional assessment of the optic nerve and the retina and the visual pathways, and that is perimetry to assess visual function. So perimetry is a systematic measurement of the visual field function. In the upper right, I'm showing an image of the static testing and a Humphrey visual field perimeter. In the bottom is the output from a kinetic testing, where there's a moving stimulus, and that is a Goldman visual field printout. At the bottom here, you're basically taking stimuli of different size and brightness, moving it into the visual field, into the field of vision. When the patient tells you that they see it and perceive it, then you can map out these isopters, which you see here in that printout. We're really trying to determine, though, what is the threshold sensitivity there, and I'll draw your attention to the middle bullet here, and that is the 50% likelihood of perceiving a stimulus of a given size and duration at a given location. And so this is a stressful test. If you can imagine that 50% of the time you may or may not see that stimulus as we find your threshold, you can imagine why it might be challenging for patients to perform. And this is a video produced by the NHS in London. Each eye is tested individually. You put your head in this bowl. There's a lens there that's in front of it to correct for this near vision if you need it. And then the test begins in a dark room. You're going to look at this fixation point in the center, and then click a clicker when you perceive the stimuli. But it's not that easy to see, as you can see. And not only that, but you have to suppress your desire to foveate to the stimulus. We all want to look at the stimulus when it's being presented, but you are being asked to focus only in the center. And so visual fields are difficult to get, reliable visual fields. It is difficult, you can imagine, maintaining that fixation. So a lot of visual field printouts will come back with high fixation loss. Also, patients get anxious about taking a test. Sometimes they become trigger happy. That will generate a lot of false positives, for example. And so visual field testing is a challenging area still in our field. So I'm going to show an example of a patient who I used to follow, and then I lost him to follow up. Well, I didn't lose him to follow up. His insurance changed, and so he could no longer be seen at UCSF, and then he went out to private practice. And so I had this sort of opportunity to see what kind of happened at beginning, and then 8 years later when he came back to see me. And he came back to see me in March 2020 because it was the beginning of the pandemic. Everywhere was closed except for some of the universities. And so he had told me that his visual field had been stable for most of the past 8 years, but was reportedly went from 60% depressed to 90% depressed in October 2019. These are actually disc drawings that I made. Now, I told you that I don't, well, no, I didn't tell you this, but I tell the trainees all the time, I don't love cup to disc ratio, primarily because I think it's a little bit subjective in terms of like someone's cup to disc ratio of 0.7 might be somebody else's cup to disc ratio of 0.5. And so I asked everybody to draw the nerve. And it's also just a habit and something that I was taught by Dave Epstein, and it forces you also to be a very careful observer of the optic nerve. So these are my drawings. Of course, there's also OCT and visual field, which I'm not showing you here. But anyway, in 2012, things were going okay. And then 8 years later, when I drew the nerves again, there was definitely enlargement of the disc. Now his pressure is high at 32 because he had a recent surgery called a Zen a few weeks earlier, but it was clearly failing because his pressure was high. And what had happened to his visual field during that time? I actually haven't shown you a full printout of the visual field, and that's partly because I don't think we necessarily need to learn how to read an entire visual field printout, but I'll walk you through here a little bit of what you're seeing here. On the top panel and on the top left is a grayscale. Here, you notice there's like kind of a round circle here. This is the physiologic blind spot. This is where the optic nerve inserts into the back of the eye. And then now there's a mostly superior, although also an inferior arcuate defect. Here, the depression is already in 2012 affecting the central superior part of his visual field. This next section here showing you the threshold sensitivities at each location within the visual field. And then next you have a total deviation map, which is a probability map, which is measuring how far from a normative database is this patient's threshold sensitivity. And then the last map is this pattern deviation map, which tells you after you subtracted out things such as like a cataract that would diffusely depress the visual field, it kind of highlights the patterns of visual field defects that you're seeing in that grayscale. And so you can see clearly from 2012 to 2020 that his visual field has progressed. And it's progressed, there's a measurement of the overall field called the mean deviation, and in this case, he's lost about 8 decibels. And so if you are losing 8 decibels over 8 years, you're losing 1 decibel per year. And that puts you in the category of a fast progressor. And so I use this figure or table to show that if you do 1 test per year, it's going to take you 4 years to detect that progression. If you do 2 tests per year, you decrease that time to detection 3 years. If you do 3 tests per year, you start getting diminishing returns, and you only go down to 2.6 years. And I mean, if you think about it, if you're a fast progressor and it's taking a few years to detect that fast progression, we're not doing this well enough. And so this is an area ripe for investigation, and I'm involved in some projects looking at home visual field monitoring, because we know that in that situation, patients can get we're asking patients, for example, to get 40 tests in 1 year, and then you can really hasten the time at which you detect. So we've talked now about OCT, we've talked now about visual field. Putting it together, the structure and function correlation is an important aspect of glaucoma diagnosis. Structure function correlation tells us that when there is a focal defect, for example, here in this superior rim, it results in a concordantly located or appropriately located inferior visual field defect. And that is because of the way that the site of damage is related to the ganglion cells that are served by those damaged axons. So here is a drawing from the basic basic science and clinical course book that we all read as residents. And here is in red the site of damage. As I mentioned earlier, the site of damage is typically at the vertical poles, and then the area served, retinal area served by those damaged axons is highlighted here in red. And then you have a corresponding inferior arcuate visual field defect here shown on the right. But that structure function correlation, first of all, is not always there. There's oftentimes discordance between structure and function. Some of that is because that you can lose, everybody has about 1 million axons, and you can lose about 20 to 40% of the axons before you see any abnormality on the visual field. And some of this work was done using histologic specimens in patients where we had matching visual fields. And it shows that 25 to 35% of ganglion cells are lost prior to typical clinical criteria for visual field abnormality. And that's why, oh, actually, I haven't talked about staging of glaucoma, but we're going to get to that in a second, and this is relevant to that. So when we compare glaucoma progression detection by OCT and visual field, this is work from David Huang's group in the Advanced Imaging for Glaucoma Study Group. Here's a group of glaucoma suspects and pre-parametric glaucoma eyes, meaning these patients don't yet have visual field abnormalities. And what you can see is that in this group, the time to detect progression in 20% of the eyes was 36 months for OCT and 60 months for visual field, about a 2-year difference. And at the 60-month follow-up, OCT detected 58% progression, which was significantly higher than the 24% detected by visual field. And so you can see that there is this time lag in early glaucoma or ocular hypertension. And part of that may also be because, I mean, there's many reasons why that might be, but one of the reasons also that it's difficult to detect progression with visual fields is because they are noisy tests. And so this is a quote from Dave Epstein in Chandler and Grant's glaucoma saying that although great strides have been made in the reproducibility of data with modern automated perimeter machines, and I would say, he wrote this in 1997, so now we can add in, there's also objective structural data from OCT. These are subjective data, and he's proposing, an objective visual field, perhaps made by recording an optic nerve response to a light stimulus placed in the retina would yield more accurate and more sensitive data. I don't have time to talk today in this talk about areas where objective measures of visual function have been investigated. There's a whole giant field related to this, but none of those have made it yet to clinical practice, which I think is an interesting problem. There's potential reasons for why that might be. But anyway, my point is just to say that we still need this. So putting it all together, structure function testing helps us stage the patient's disease, and it also helps us assess the rate of progression. Ideally, actually, these patients are stable. This is an image showing the optic nerve and then these heat maps, density maps of the retinal nerve fiber layer thickness, as well as the ganglion cell complex in the macula. My point in showing you this is related to staging. So you can see here in the top row, this is a normal visual field on that grayscale map. Again, that dark spot is the blind spot. This is a left eye, and it is mild or pre-parametric glaucoma, so you don't have to have any visual field abnormalities detected on our test. Doesn't mean you don't have visual field abnormalities, just as detected by this test. Moderate is staged as if you have a hemifield defect, involving only one hemifield, as long as it's outside the central 5 degrees. And severe advanced disease is defined as involving both hemifields, or you can only involve one hemifield, but if it presents as in the central 5 degrees. And there are forms of glaucoma or patients who present that way, and of course, given the proximity of that field defect to the center, we consider that severe or advanced disease. And then examples of progressive retinal nerve fiber laying and visual field defect is, here it's so obvious in this example that I've shown you, but I suppose one of the reasons I showed this to you is to just bring up the point that it's not always so obvious. There's, as I said, noise even in the structural tests when we obtain them, and visual field tests, you don't oftentimes see a change from nothing to this defect, the superior arcuate defect that you see on the right-hand side. But here there's 8 years that have been elapsed. But you can imagine if you're obtaining these tests every 6 months or so, you're looking for more subtle changes, and it's difficult to tell, is this above the noise within this test? So we're going to move now into treatment, and the general principles guiding treatment are that we need to preserve visual function by setting and achieving a target IOP that is unlikely to produce a progressive neuropathy, and we want to slow the disease enough to preserve vision over time. We want to balance this goal with risk and adverse events, the patient's quality of life, and when patients present with more advanced glaucoma, we want to lower this target IOP. Target IOP is a principle that I'm already running out of time, so I am going to just say that it is the pressure at which you as the clinician make this judgment that the patient is not likely to progress with this target eye pressure. We might need to continuously revise that IOP goal though, and we need to treat the underlying cause, and we actually need to constantly evaluate for efficacy, although really our assessments are periodic. So treatments, all current treatments are aimed at lowering IOP currently. That's the only treatment we have, and that includes medications, laser, and surgery. I am going to now very briefly touch upon medications because this has been addressed in previous glaucoma fast tracks. But needless to say, there are medications that address uveal scleral outflow, aqueous humor production, and until more recently, we didn't have really great medications that directly address trabecular meshwork outflow until the advent of Rho kinase inhibitors, which have multiple mechanisms of action, including this new one down below. It's thought to potentially lower episcleral venous pressure. Okay. Okay. So the side effects and unmet needs in glaucoma medication treatment are significant. These are just images of eyes that are red. They have eyelash growth, which actually, to prostaglandin analogs, which actually has been now marketed into a cosmetic thing called Latisse. But anyways, it can cause periorbital orbitopathy. It can cause severe ocular allergy. It can also cause severe redness that patients just don't tolerate. And also putting medications in is not easy. Patients also oftentimes do it right. I mean, that's a whole separate talk about adherence, persistence with treatment, the battles or the barriers that we have there, and strategies to improve that. But I would say this is an area that needs work in terms of getting durable IOP lowering with overcoming the issues with patient adherence. Okay, laser. Laser, I included this photo because I just love it. I mean, it looks like, you know, something out of like, you know, the 1980s, and that is not the laser beam. That's not what it looks like. But the reality is when I took this, had one of the technicians take this photo yesterday, yeah, it doesn't look that different. And here's the laser beam coming now. But so selective laser trabeculoplasty is an excellent treatment. This is an animation that is supposed to be showing like macrophages invading the trabecular meshwork, causing cellular remodeling. All these amazing things are happening now. The outflow track is better. But I included this video really for this part just to show you what the laser itself looks like. The patient sits at a slit lamp-like looking device that I just showed you, and then you put a mirror on, and then you see those little bubbles that are kind of flicking off there when you apply the laser. And so this procedure is fast. This part of the procedure to do this, you know, is really just 5 minutes. And I think game-changing study was really, the first one was the LIGHT study, and this is a study done out of the UK. Very briefly, it was basically randomizing patients, half of them to laser, newly diagnosed glaucoma or ocular hypertension, to laser or medications. And what it found essentially is that laser is as effective as eye drops for initial eye pressure lowering. They had lower rates of disease progression and surgery, slower rates of visual field loss, excellent safety profile, more cost effective. I mean, basically, really all good things. And so laser really has, I mean, even before this study, we knew that laser could likely be offered as first-line therapy, but now really these guidelines are saying, let's do laser as first-line treatment. So surgery, we're gonna move into this briefly, and the big picture here is that there's a lot of different surgeries, but currently I would say you can kind of put surgery into more powerful but higher risk surgeries called trabeculectomy and tube shunt surgery, and more safer surgeries called minimally invasive glaucoma surgeries that are safer but also have lower efficacy. And our decision making is really based on the patient's glaucoma stage, their target pressures, the therapeutic goals. And so in trabeculectomy, essentially what we're doing is what I tell patients is we're making a small hole in their eye wall under this flap here. And we can actually titrate the procedure after the surgery. It's the only titratable glaucoma surgery we have because we can release those sutures or laser those sutures or lots of different ways, but you can essentially release them and allow more flow. And so this is an example of the surgery where we're producing a little pocket under the conjunctiva or space under the conjunctiva and Tenon's capsule, and then created this scleral flap. We then make an incision into the anterior chamber using a blade, and then we use this device called the Kelly punch here to cut out this sort of half moon of tissue. It's called a trabeculectomy. It's kind of a misnomer because you're really cutting cornea sclera, and then we're moving a little piece of that iris so that it doesn't block that sclerostomy. So I want to just say, I don't have time to go through this data, but it is essentially to share with you that actually trabeculectomy can actually improve long-term visual function. We think that glaucoma is irreversible, but in this study from Joe Caprioli's group where they're looking at visual point locations, that line, that vertical line that you see is this time of trabeculectomy. And you can see that those points before the trabeculectomy are decreasing and then they rebound or stabilize after surgery. And I have seen that myself in my own patient. This patient developed this central or paracentral depression here that then reversed after I did their trabeculectomy. So I would say that yes, glaucoma or the ganglion cells are functionally impaired, but they're reversible. We have preclinical evidence for that, including work done by members of this audience. And also there's clinical evidence that we can reverse functional impairment. And then, can we build a better mousetrap? There are also glaucoma drainage devices. These are devices that kind of look like actually a computer mouse. You fit the plate in between the eye muscles, and then the tube then enters the eye. And in this video, we're just showing you an implantation. I'll just quickly show you that they had a prior trabeculectomy here that was scarred, as you can see here, and now they're undergoing a tube shunt implant. So now we're pushing that into the pocket there and then suturing that to the eye. And then I'm not going to talk about MIGS, because guess what? That was covered by Dr. Herndon in a previous fast track talk. Needless to say, there are lots of different minimally invasive glaucoma surgeries. They're oftentimes coupled with cataract surgery. I'll show you this very brief video. This is that stripe of red actually is the trabecular meshwork being highlighted. There's some reflux already that's sort of happening and kind of highlighting for us the tissue that needs to be excised. And so this is a Cahook dual blade, which is excising the trabecular meshwork and unroofing Schlemm's canal. And you can see there's some reflux bleeding back into the anterior chamber. So I would say that there's, I tried to show you some of the current state of clinical advances in the last 5 years. These are some of the newest treatments and newest areas of clinical advances. And there's lots of different areas which we're gonna hear about this afternoon too, with regards to genetic risk profiling, new therapeutics, AI-assisted diagnosis. And so to summarize, primary open-angle glaucoma is generally a slowly progressive optic neuropathy for which there are many opportunities to reverse or stabilize the disease. And our patients need better and more durable ways to lower IOP and also therapies that go beyond IOP. Our current structural and functional assessments are helpful and important, but we certainly can do better at identifying fast progressors or high-risk patients. And so I would say I have another section, but I'm going to stop here, that talks a little bit about what are the unmet clinical needs, what areas can you help us on. Come and talk to me, because I think that is the benefit of this meeting. My take-home message to you is that it's always fun to talk to people who are new or newish to the field, because you bring new ideas, you question current paradigms that we sometimes get stuck in. And so I encourage you all to talk to everybody at this meeting, and hopefully we can come up with new solutions. Thank you.
All right, we're open for questions. We have 5 minutes. That was a great talk. I'll just go over here.
Yeah.
No questions?
Oh, Brad has a question.
Don't be shy.
Oh,
can you bring him a microphone, please?
I'm sure there are better questions. I have a question. Can
Okay.
I ask a question?
Yes.
So great talk, Yvonne. You were the perfect person to give this talk. It was awesome.
Thanks.
Could you talk to us a little bit about, why patients don't detect these scotomas that are forming in their eye? Like a little bit about what the saccade is and how it works and how this is sort of foiling us from the patient actually noticing something wrong?
I'm sorry, you said saccade? I didn't.
The saccade.
Oh, saccade. Oh, sorry. I didn't. Okay. I think, one of the things I didn't talk about in this talk is that, there's also a large issue with identifying all the patients that have glaucoma. I mean, we want to do that, right? Because I told you, actually I didn't say this in the talk, but 50% of patients have glaucoma but don't know it, speaking to the issue that and my patient that talked during this presentation was one of those patients, right? She just happened to get detected finally. But identifying all the early glaucoma patients is also a big deal for the field, because now we have to figure out, well, what are we going to do? Because that's a lot of that's a lot of patients. It's a lot of strain on the medical system. It's a lot of patients who need to be treated or maybe don't need to be treated. I mean, that's another question in the field. Like Jamie Brandt gave a talk talking about, the worried well and patients who have early mild glaucoma. Those patients, they don't detect their visual field defects. These are small, either they don't have a visual field defect or they have very small scotomas that they don't perceive. Now, taking the totally opposite end of the spectrum, those are the patients really we want to detect earlier before they get to that point, because we do know that treating earlier prevents them from getting to that location getting to that point of their disease. I think though when they are at that late point, those patients will tell you that they can perceive their visual field defect. It's just the problem is that also glaucoma is an asymmetric disease, and I think oftentimes the fact that one eye sees well or nearly completely well versus an eye that has these scotomas, there's also aspects that we didn't talk about where the brain is also compensating and filling in the scotoma and preventing patients from detecting that they have something going on. And so our job is to really find those patients a little bit earlier than before they get to that point, and also not to undertreat these patients with advanced glaucoma.
Great. Next question over here.
Mine was, you may have been at I think it was like one of the very last sessions at this past ARVO. We had a good debate about staging.
Yeah.
Because I was kind of being devil's advocate saying, what's the point? We have all these beautiful continuous variables, nerve fiber layer thickness, GCC thickness, mean deviation, all these continuous variables. What is the reason for doing staging to make it some discrete thing like early, moderate, and late? Why do we do that? Why do we care?
Well, that's a great question in the sense that there's lots of different answers, I think, depending on your perspective. I didn't say this too. I showed you one way of staging disease. That is the American Academy of Ophthalmology method. But of course, in research, we use other methods. For example, we could use a more continuous, such as RNFL thickness. But there's the Hodap-Anderson-Parrish criteria, which stages the disease based on mean deviation. I think knowing the stage of the disease does help us. There are important clinical aspects that come into play. I just told you we don't want to undertreat advanced glaucoma. Those patients, though, that patient that I showed you with that I lost to follow-up for 8 years, that patient was high risk for surgery, too, just given the location of that visual field defect involving the central 5 degrees. So I think these aspects are important for us to classify. But I agree with you. It's not like, these are separate, very discrete categories.
All right. One more question, even though we're at zero time at the back.
Hi. I have, actually, my question is 2 parts.
No, one part, please.
That's why I said one question, 2 parts. I'm looking more of a diagnostic part here. I saw that you use photopic negative ERGs. Why don't we use the other ERGs like pattern or multifocal ERGs because they don't need dark adaptation, and it's much faster. And,
yeah.
Sorry, go ahead.
Yeah, that's a great question. I alluded to the fact that there's a whole field of research measuring objective tests of visual function. Why aren't we doing it? That is a great question. I've asked people because I do think it is curious to me that we have these methods such as pattern ERG to directly measure ganglion cell function, yet we don't use them clinically. And I think part of it is that there's still no standardization of these protocols across different labs and the published literature. There's also test-retest variability and noise, which makes it difficult to monitor progression, which is ultimately what we also want to be able to do, not just diagnosis. Although, you can kind of look at these diagnostic tests from the standpoint of just like, can we diagnose? What's the diagnostic accuracy? And then another that gives you progression. And then finally, though multifocal ERG gives you spatial information, some of these other measurements don't, right? And so they become, in some ways, they miss out that aspect, which is an important aspect.
I'm sorry, you have to ask the second one later, get together and talk about it. Great, thank you. Thank you.